Okay, this was a 65-year-old male who presented via ambulance. He had a past medical history of COPD, HIV, hypertension, coronary artery disease, peripheral vascular disease, and he abused substances. And he was struck by an automobile at an unknown speed. He had stable vital signs and an obvious left leg deformity that he reported as 8 out of 10 pain. Sensation was intact in this leg to the superficial fibular, deep fibular, and tibial nerves. And then the motor exam was also intact in the extensor hallucis longus, flexor hallucis longus, tib and gastrocsoleus complex. These are the patient's initial radiographs prior to reduction. On the left side of the screen, you see the PA view, and on the right side of the screen, the lateral. And what you can see here is that the tibia and the patella are both rotated laterally relative to the distal femur. So he has an anterolateral dislocation with a rotational component, very violent mechanism required to do that. And you can imagine the soft tissue lesions that we're going to find. So let's talk about knee dislocations. It's a disruption of the normal articulation of the femur and tibia, and by definition, a catastrophic injury. It's also important not to confuse with patellar dislocations, which happens, unfortunately. About half of these resolve, or reduce, I should say, spontaneously prior to evaluation, and thus are commonly missed, so it requires a high index of suspicion. They're very rare, representing less than 0.5% of all joint dislocations. Most of them are closed, however, about 1 in 6 or 1 in 7 are open. Mechanism is typically violent. I would say the most common is motor vehicle crash, but of course fall from height, industrial accident, anything with a high force or high velocity. Less commonly sports and sports-related activities. And then rarely, but increasingly common in the United States, would be morbidly obese patients with spontaneous knee dislocations. In terms of direction, most commonly anterior followed by posterior, and then medial, lateral, and rotational. Associated injuries are unfortunately rather dramatic. You almost always have at least a multi-ligament knee injury that includes ACL, PCL, MCL, and LCL. You typically have a assortment of other lesions, including the distal biceps femoris, the popliteus tendon, either meniscus or both, chondral lesions, bone bruises, fractures, and injuries to the extensor mechanism as well. And then the most important structure here is the popliteal artery, and depending on what study you're looking at, about between 18 and 64% of patients with a knee dislocation suffer some type of injury to the popliteal artery. Of all the nerves that can be injured, the peroneal nerve is the most common. Differential diagnosis when considering this violent trauma would include a knee dislocation, a patella dislocation, distal femur fracture, proximal tibial or tibia or fibular fracture, a multi-ligament knee injury, which should be considered a knee dislocation equivalent, extensor mechanism injuries, and then isolated ligament injuries. History and physical, you should be able to clarify a violent mechanism in the patient. There may or may not be a deformity. They aren't going to be able to walk. They're going to have a sensation of instability if they do try to walk. They may have this so-called dimple sign, which is demonstrated here, which is quote-unquote buttonholing of the medial femoral condyle through the medial capsule. And then it's important to do a careful structural exam and neurovascular exam. This is one proposed treatment / workup algorithm, right? So you have a knee dislocation, you need to reduce the knee, following radiographs, by the way, just to make sure there's no fractures. If it's ischemic after the reduction or before, that patient needs to go to the operating room. If the limb appears to be well perfused and the ankle brachial index is greater than 0.9, then you can observe them with serial examinations. If the limb is well perfused but the ABI is abnormal, or if the pulses are asymmetric or absent, then you need to pursue a CT angiogram of that extremity. In the acute setting, you want to follow your ATLS algorithm. Depending on the mechanism, there may be other injuries that are more catastrophic or more concerning during a primary or secondary survey. Once you're focused on the knee, get the x-rays to confirm there's no fracture. You can apply gentle traction distally, and it will typically just pop right into place because it's so lax. And then you need to immobilize it in extension. If there's any ischemia present, you're going to go straight to the operating room. And then you'll also go for open injuries or irreducible lesions as well. In the subacute setting, you basically are going to plan a staged reconstruction of all these soft tissue injuries. Non-operative management is rare because patients do not have good outcomes, but those who are poor surgical candidates and elderly, et cetera, may not require surgery, and that is a discussion to be had with the orthopedic surgeon. And then you have to undergo sort of extensive rehabilitation during this staged reconstruction. In terms of prognosis, well, patients do better with operative management. They have better functional outcomes. Early is generally better. That doesn't mean that they do well. Your knee will never be the same. The feared complications are popliteal artery and perineal nerve injury. And one study found that up to 85% of cases will require amputation if the limb is not treated and fixed in the first 8 hours, which is pretty concerning. And then more chronically speaking, patients are going to develop some flavor of traumatic osteoarthritis, chronic pain, arthropfibrosis, stiffness, and persistent instability. So what happened with our patient? Well, CT angio was considered, but the trauma team decided to admit him for serial examination. MRI was obtained while he was in the hospital, and he had an ACL, a PCL, FCL, which is fibular collateral ligament, an MCL, popliteus tendon, proximal head of the gastroc, medial meniscus, bucket handle, lateral meniscus, and an osteochondral lesion. Those are all things that were torn. The popliteal artery, which I don't think I mentioned here, was intact. The patient was discharged to subacute rehab with a plan to perform staged reconstruction of that knee. So let's talk about 3 key points for knee dislocation. The first is their catastrophic injury to the femorotibial joint. They involve injury to multiple ligaments and internal structures of the knee, and almost universally require surgery for a staged reconstruction of those ligaments. The feared complication is a popliteal artery injury, which is unfortunately relatively common and requires emergent evaluation and surgical correction when present.